Good evening, everyone. I first of all thank this extracorporeal group. I thank GKN sir and Binu Bendran sir for that nice introduction, and also this opportunity for giving me this opportunity to speak. So this is a very important topic in our day-to-day practice. As such, it's a basic topic. So I will go from the basic to the advanced management. I will try to make it crisp. Just bear with me if there is any flaws. So we see this hyponatremia. It is common in the news that we hear that long distance marathon runners and the soldiers who work in the heat and associated with stress, who drink a lot of hypotonic fluid, come just underwent sudden cardiac death because of some cerebral edema and all these things. So this hyponatremia is there everywhere commonly. So going on to the definition, it is defined when the serum sodium concentration is less than 135 millimole per liter. And it's basically a disorder of body fluid and electrolyte balance. And this can be symptomatic or asymptomatic. It is symptomatic with severe symptoms of cerebral edema or with moderate symptoms. Without asymptomatic, in asymptomatic cases also, it can present. And looking at the profile of patients, most common symptom is vomiting in 28% of the patients, followed by confusion, followed by seizure and coma. And hyponatremia, as we all know, it is a disorder of sodium balance. It's sodium. It's basically a disorder which occurs due to derangement in the water balance. So we can see the serum sodium. It's basically total body sodium divided by total body water. So hyponatremia can result either from a decrease in the numerator or increase in the denominator. And symptoms often correlate with the severity and the rate of decline in the serum sodium. It can be asymptomatic to mild non-specific symptoms, and it can go to underlying symptoms from the underlying disease process can also present in this ascending order of occurrence. So in before understanding hyponatremia, we need to understand basically about this hormone, which is arginine vasopressin. It is actually a peptide hormone with 9 amino acids, and it is synthesized from the supraoptic and paraventricular nuclei of hypothalamus. It's transported from hypothalamus to the neural lobe of pituitary, and it is a hormone which regulates urinary water excretion. So AVP or arginine vasopressin, it acts through 3 receptors, basically V1A, V2, and V1B receptor. V1A is present on vascular smooth muscle cells and platelets, where it mediates vasoconstriction as well as myocardial stimulation along with platelet aggregation. And the receptor which is most important in our case is the renal cortical collecting duct principal cells, which is a renal which regulates the free water reabsorption. And also V3 receptor or V1B receptor are present in the anterior pituitary, which is not of much significance to us. So I would just like to go into the basic. To know about it, we have to understand that the collecting duct is permeable to water only in the presence of ADH. So this is the scenario which happens in the absence of ADH. In the absence of ADH, aquaporin 2 are present as vesicles itself inside the collecting duct cell, so that this collecting duct is impermeable to water without ADH. But see, this is a scenario in the presence of ADH. That is, when ADH binds to this V2 receptors, it causes the translocation of aquaporin 2 from inside the vesicles to the luminal surface, and thereby it causes the reabsorption of water across the membrane. So only in the presence of ADH, the collecting duct is permeable to water. And this is a cellular pathway. As we all know, vasopressin binds to V2 receptor. It causes activation of adenylate cyclase, which converts ATP to CAMP. It activates protein kinase A, which causes phosphorylation of aquaporin 2, which thereby causes insertion of aquaporin 2 onto the luminal membrane, which causes reabsorption of water. So this is some basic. So we know what are the stimulus for ADH. The first and the basic stimulus for ADH is osmolality. Whenever there is increased serum osmolality, it causes secretion of ADH. Other than osmolality, there are non-osmotic stimulus also, which is the decreased blood volume or decreased arterial pressure can also stimulate the ADH release. And the opposite reduces, like when there is reduced osmolality, increased arterial pressure, ADH secretion is reduced. And it basically acts on the V1 receptors to cause vasoconstriction and myocardial stimulation, and on the V2 receptors to cause renal water reabsorption. So the types of hyponatremia, based on the latest guideline, it is classified as mild when it is between 130 to 134, moderate 125 to 129, and profound when it is less than 125. And this common classification you all would have seen, and it is based on the osmolality. Basically, we will see the osmolality. If the osmolality is normal, that is called hypotonic hyponatremia. That is also called pseudo hyponatremia. It is due to the presence of lipids and proteins. The other one is hypotonic hyponatremia when the osmolality is less than 280. That is the true hyponatremia. And when the osmolality is high, it is called hypertonic hyponatremia or translocational hypernatremia. I will be just discussing about this in. So this is what happens in pseudo hyponatremia. Pseudo hyponatremia, it is actually a laboratory artifact. It is due to abnormally high concentration of lipids and proteins. It is more frequently seen with the flame photometric measurement than with ion selective electrodes. So what happens basically? We see this is the condition. Normally, what happens is that the serum contains 7% solids by volume. But if due to some reason the concentration of the solid phase increases by more than 7%, this estimation of serum sodium goes wrong, because basically dilution of dilution of the serum is involved in the process. See, in this condition, standard volume of diluent is added because the lab technician does not know whether there is hyperproteinemia or not. So when an equal volume of diluent is added to this serum appears more dilute, whereas this serum appears more concentrated. And this is the reason for this pseudo hyponatremia, which is basically a laboratory artifact, and measurement of serum sodium in an undiluted sample will settle this issue. And what about this translocational hyponatremia? And to understand this translocational hyponatremia, we need to understand something like what is osmolality and what is tonicity. So osmolality means the number of effective osmoles present per kilogram of solvent. And what is tonicity? Is tonicity same as osmolality or is it different? Yes, tonicity is not always the same, because we need to understand what is meant by effective osmoles. Imagine the presence of sodium and glucose in the absence of insulin in the serum. These are substances which do not cross the plasma membrane. They retain inside the extracellular fluid and they reabsorb water. They cause shift of water from the cells to the ECF. Thereby, we can tell that these effective osmoles increase the plasma osmolality as well as it increases the plasma tonicity. Whereas when there is substances like urea, ethanol, and methanol, they are called ineffective osmoles because they do not readily cross the cell membrane and they do not cause movement of water between the compartments. So we can tell that they cause increased plasma osmolality, but they do not cause increased plasma tonicity. And what causes this translocational hyponatremia? When there is presence of these effective osmoles in the circulation, then that causes shift of water and it causes translocational hyponatremia. It's not a real hyponatremia because the total body sodium and total body water remain same. It's just the shift of water between the compartments. And this classification based on volume status is also familiar to all of you. And what we have to see is like we can classify it as hypovolemic, euvolemic, and hypervolemic hyponatremia. In hypovolemic hyponatremia, there is reduction in body water, but the reduction in sodium level is more. And we can see it can be due to renal loss or non-renal loss, as in gastroenteritis. And in hypervolemic hyponatremia, there is increased total body water, and the increase in water is more compared to increase in sodium, as in cases associated with congestive heart failure and cirrhosis, where there is reduced extraarterial blood volume, and when the urine sodium is more than 20, it happens in renal failure. And then we have the more common euvolemic hyponatremia, which I will be discussing in detail now. So to understand hyponatremia, this thing has to be understood. So see, basically, we have to understand that urine sodium almost always reveals RAS activity, but except in cases of diuretic use or renal failure. Urine osmolality almost always reveals ADH activity, and ADH secretion is appropriate only when RAS is active. So this concept has to be kept in mind. And see this graph. Whenever there is reduction in effective arterial blood volume or EABV, this RAS activity increases. Okay, and this is the condition. So when there is reduced EABV, this ADH gets secreted. So this is an appropriate secretion of ADH in this condition. And what happens? We can't directly measure the ADH level. So urine osmolality has to be taken as a surrogate marker of ADH. So whenever ADH increases, urine osmolality increases. So in this condition, urine osmolality increases so that more of free water gets reabsorbed and the urine goes, lot of concentrated urine gets passed. and the body tries to conserve more of sodium. So the urine sodium gets reduced, fractional excretion of sodium gets reduced. Whenever the sodium gets reabsorbed, more of uric acid also gets reabsorbed with the sodium. So the serum uric acid increases and the fractional excretion of uric acid gets reduced. So this is the situation which happens in conditions like hypovolemia, heart failure, and cirrhosis. So this is an appropriate response to ADH. Imagine this condition when there is lot of effective arterial blood volume is normal and the urine osmolality is low because ADH gets suppressed at this condition. So the urine osmolality gets low. And when it is accompanied by low solute or high water intake, we see this condition in mainly primary polydipsia, T and TOS syndrome, or Beer-Porter-mania. So this green zone falls in the range of expected range of ADH response. But see here, what happens? Even though the effective arterial blood volume is normal in this case, but the urine osmolality stays high because there is some other stimulus to ADH secretion. ADH gets inappropriately secreted. In that condition, since the body does RAS system is not activated, urine sodium is high and the uric acid will be low. Fractional excretion of uric acid will be high. So this mechanism should be kept in mind while dealing with this. Again, going on to SADH diagnostic criteria, you all will be knowing we have 5 essential criteria where there is serum osmolality. There should be documented hypotonic hyponatremia and the urine osmolality should be more than 100. There should be clinical euvolemia and the urine sodium concentration is more than 30 with normal dietary sodium and water intake. And one thing to be kept in mind is that in the presence of renal failure, we do not diagnose this as ADH. Adrenal, thyroid, pituitary, or renal insufficiency has to be ruled out before diagnosing SADH. And there is no recent use of diuretic agents. So supplemental criteria also, I just mentioned in the previous slide. So I'll be going on to the next. So while we see a case of SADH, we should keep these conditions in mind. Especially, we have to rule out these underlying causes. It is most commonly associated with this odd cell carcinoma or the small cell carcinoma of the lung. This has to be ruled out. And also underlying pulmonary disorders and underlying CNS disorders, meningitis, head trauma, brain abscess, all these has to be ruled out whenever we see an SADH. And see this also. These are the drugs. We should take a detailed drug history and see this vasopressin analogs, oxytocin, and the drugs which potentiate the renal action of vasopressin, like all the C's, chloropropamide, cyclophosphamide, NSAID, acetaminophen, and the drugs which enhance the vasopressin release, like again chloropropamide, clofebrate, carbamazepine, and all the drugs, antipsychotics, as well as SSRIs, tricyclic antidepressants. All these should be kept in mind when we encounter a case of hyponatremia. And we see hyponatremia, euvolemic hyponatremia occurs in secondary adrenal insufficiency as well as also hypothyroidism. We see the mechanism of it. In secondary adrenal insufficiency, what happens is there is uh, reduced secretion of ACTH from the pituitary. So cortisol is not secreted. Cortisol is one thing which causes a negative regulation of CRH as well as vasopressin from the hypothalamus. When this negative regulation does not happen, negative feedback does not happen, vasopressin is inappropriately secreted, as in the case of SADH. And next is hypothyroidism. Uh, I haven't seen any cases of hypothyroidism causing hyponatremia, to be frank. In fact, it's a very rare thing because the serum sodium decreases by only 0.14 for every 10 increase in TSH. That means if the TSH is 100, the sodium decreases by only 1.4. So to have a clinically manifest hypothyroidism, then only we will have a clinically significant hyponatremia in case of hypothyroidism. And the mechanism is that due to mixed edema, there is reduced cardiac output, there is non-osmotic release of AVP. Okay, so we see those conditions where ADH is secreted, and whenever we see a euvolemic hyponatremia, when the urine is dilute, then that means AVP is suppressed in this condition. This can happen only in these 3 conditions: when the patient takes too little of solute with normal fluid intake, as in case of tea and toast diet which the patient takes, or too much fluid despite normal solute intake, as in case of primary polydipsia, or low solute and high intake of hypoosmolar fluid, as in case of Beer-Porter syndrome. And the talk about hyponatremia is incomplete when without talking about this mechanism of action of loop as well as thiazide diuretics. We know thiazide diuretics commonly cause this hyponatremia, whereas loop diuretics are used in the treatment of hyponatremia. So this mechanism has to be kept in mind. So what happens is like thiazides inhibit the sodium chloride co-transporter in the DCT, and it causes a sort of diuresis. It activates AVP, and in the presence of thiazides, when AVP is activated, Since the medullary concentrating osmotic gradient is maintained, this AVP can act and it causes more of sodium reabsorption, more of water reabsorption. But see, in the case of loop diuretic, what happens? It blocks this NKCC2 channel in the thick ascending limb. So the gradient which is required for the maintenance of this SA, here also ADH gets activated, but there is resistance to the action of ADH because this medullary osmotic gradient is not maintained due to the presence of this, due to the blockage of this NKCC2 channel. So this is why thiazides cause hyponatremia, but loop diuretics cause hypernatremia. And based on the classification, based on the onset, we can classify it as acute as well as chronic. Acute is one which happens in less than 48 hours, which can present with significant neurological features causing cerebral edema from seizures, altered mentation, and coma. Whereas chronic happens over more than 48 hours. So in all those conditions in which the onset is not known, we have to treat it like a chronic hyponatremia. And these are some of the commonest conditions which are associated with acute hyponatremia. As in case of post-operative phase, where there is stress stimulates the release of AVP, as well as we give a lot of hypotonic fluids. Post resection of prostate, post resection of endoscopic surgery, polydipsia, exercise. As in case of these long distance marathon runners, they will be under stress. There will be non-osmotic release of AVP. Along with that, if the marathon runner takes in a lot of hypotonic fluid, it will result in sudden brain swelling, acute hyponatremia, and sudden death. So these are some of the causes of acute hyponatremia. And what happens in hypotonic state? There is cerebral swelling in acute hyponatremia. And when it happens less than 48 hours, there is no time for the brain for adaptation. So the extracellular sodium decreases by either sodium loss or water gain. When there is a lot of excess water, this water moves into the brain along osmotic gradient and it causes symptomatic cerebral edema. When the brain swelling exceeds more than 8%, it exceeds the skull's capacity and it causes herniation of the brain and death. So this is what happens in acute hyponatremia. But in chronic hyponatremia, there are a lot of compensatory mechanisms by which that causes a loss of electrolytes and osmolytes from the brain. It reduces the brain solute content so that there is not much gradient left for the water to come in and cause brain swelling. So brain edema is virtually absent in case of chronic hyponatremia. And these are some of the consequences of hyponatremia, which can vary from osteoporosis, fractures, gait disturbances, and falls in the elderly to increase rates of ICU admission, seizures, and coma. And the most common cause of hyponatremia in the medical ICU is SAADH, followed by renal loss, followed by GI loss, followed by cardiac and cirrhosis and drugs. And these are the patients whom we should be more careful about the risk of cerebral edema, because children under the age of 16, they have a higher brain to intracranial volume ratio. And women, because of the effect of sex steroids, which inhibit the brain adaptation, there is increased vasopressin levels. The cerebral vasoconstriction and hyperperfusion of the brain tissue also happens. When there is hypoxemia, there is impaired brain adaptation. And in case of ecstasy use, there is inappropriate ADH secretion. So all these people are under high risk of developing cerebral edema from acute hyponatremia. So how to evaluate this thing? So a detailed history and clinical examination is needed. A drug and diet history of volume loss, diarrhea, vomiting should be noted. And the clinical volume status should be ascertained, as in case of dehydration, edema, ascites should be noted. Orthostatic blood pressure and dry mucous membrane should be noted. So any signs of hypothyroidism or adrenal insufficiency, and also a detailed examination to be done to detect any CNS or lung lesions. And this is how to approach the hyponatremia. I'm just giving a bird's eye view. First thing we have to see is, whenever we see hyponatremia, we have to see whether it is symptomatic. If it is symptomatic and the patient is having severe symptoms, then just treat the hyponatremia rather than go on to evaluate the hyponatremia. If it is asymptomatic or there is only mild symptoms, then the next step is to ascertain the serum osmolality. And serum osmolality, we have to rule out pseudo-hyponatremia on this side, and we have to rule out translocational hyponatremia on this side. And once we find that the hyponatremia is due to it is hypotonic hyponatremia or true hyponatremia, the next step is to assess the volume status. And I'll be presenting one more approach. We can look into that. And based on the volume status, we can see going to the treatment. Like if it is a hypovolemic hyponatremia, the treatment is isotonic saline. If it is a euvolemic hyponatremia, the treatment is fluid restriction. If it is a hypervolemic hyponatremia, the treatment is always diuretics, fluid, and sodium restriction. So this is the best approach which I found recently in the European guidelines. So whenever we see hyponatremia, exclude the hyperglycemia as well as other causes of hyponatremia, like exclude pseudo-hyponatremia, exclude translocational hyponatremia. And we ascertain it is hypotonic hyponatremia. Next thing is to look whether there is any acute or severe symptoms. In those cases, go and treat it with hypertonic saline immediately. But when there is no acute or severe symptoms, then the next step is to determine the urine osmolality. And if the urine osmolality is less than 100, then the diagnosis is one of these: primary polydipsia, solute intake, low solute intake, or beer potomania. But once the urine osmolality is more than 100, the next step is to assess the volume status. Volume status can be ascertained by urine sodium concentration. I told, whenever there is reduced effective arterial blood volume, the RAS system gets activated, so the urine sodium will be less than 30 in most of the cases of hyponatremia, except when there is recent diuretic use or when there is associated renal disease. So when the urine sodium is less than 30, we find that there is low EABV. Then we have to see the ECF volume. If the ECF volume is high in such a situation, then the cause is heart failure, cirrhosis, or nephrotic syndrome. If the ECF volume is reduced, then it is a diarrhea, third spacing, or remote use of diuretics. But when the urine sodium concentration is more than 30, then we have to see whether it is due to diuretics or kidney disease. If it is due to diuretics, then treat accordingly, withdraw diuretics. If urine sodium is more than 30 and then ECF volume is reduced, then we have to rule out causes of renal salt wasting, as in case of primary adrenal insufficiency, cerebral salt wasting, occult diuretics. If the ECF volume is normal, then we have to consider SIADH. So basically, SIADH is a diagnosis of exclusion which comes last in the chart. And the overview of management. The most important management factors are based on the severity of neurological symptoms, volume status, whether it is acute or chronic, and the likely cause of hyponatremia, and the serum sodium assessment. And these are the management options which we have: either saline infusion, fluid restriction, demiclocycline, loop diuretics, AVP receptor antagonist. And when to consider this hypotonic saline? And this has to be considered in these conditions: symptomatic hyponatremia with seizures and coma, acute severe hyponatremia, which happens less than 24 hours and the sodium is less than 120, hyponatremia which is worsening on normal saline, and we induce these hyponatremic states for also management of cerebral edema. And fluid restriction, is it a very effective strategy? Not always. And in some of the conditions which predict the failure rate to fluid restriction is when the urine is very concentrated, as in case of when the urine osmolality is more than 500, and when the urine electrolytes sum is more than the serum sodium. That means urine is very concentrated. That's a predictor of failure. And when the patient is not having any aqueresis, then the output will be low. In that case also, fluid restriction won't do good. And when the increase in sodium is less than 2 in 24 hours after fluid restriction, then we have to go into next measures. And at brief about the AVP receptor antagonist, we see the vaptans. Conivaptan, tolvaptan, and lexivaptan are the available vaptans. Conivaptan is a mixed V1A and V2 receptor antagonist, which is the available only in IV form. The other two are available as oral form. And the only thing currently which we can tell is we can't use it in hypovolemic hyponatremia. We can use it in the treatment of euvolemic and hypervolemic hyponatremia only. So going on to the treatment proper, firstly we assess whether it is severe or not. If severe, how severe? If it is moderately severe, as in case of nausea without vomiting, confusion, headache, or it is very severe, as in case of vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, and coma. So this is the latest algorithm for management. If there is severe symptoms, then go on to treat with hyponatremia with severe symptoms. If there are no severe symptoms, look for moderately severe symptoms. If it is not present, then see whether it is acute hyponatremia. If all these three are ruled out, then we can assume that it is a chronic hyponatremia. If it is a chronic hyponatremia without severe or moderately severe symptoms, then we have to see what about the circulating volume. If the circulating volume is reduced, then treat the reduced circulating volume. If it is not, then see whether it is expanded circulating volume. Then we have to treat the expanded circulating volume. If the volume status is euvolemic, then treat it as SADH. So this is the management. So I told, whenever we have a patient with symptomatic hyponatremia and it has severe symptoms, we have to treat immediately with infusion of 150 ml 3% hypertonic saline over 20 minutes. And while the next saline infusion is going on over 20 minutes, we have to check the serum sodium level again. And the target sodium level is 5 millimole increase in serum sodium concentration from the baseline, which usually settles off the symptoms of hyponatremia. And when there are moderately severe symptoms, in that case, we can take some time actually. We can go for some cause specific treatment. But it is suggested to give an immediate treatment with a single infusion of 150 ml 3% hypertonic saline over 20 minutes. And we should aim for only a 5 millimole per 24-hour increase in serum sodium concentration in this case. And we should limit the increase in serum sodium concentration to 10 in the first 24 and 8 every 24 hours thereafter until we reach sodium of 130. And the sodium should be checked after 1 hour, 6 hour, and 12 hour. And when there is acute hyponatremia without severe or moderately severe symptoms. So these are the three scenarios. In this condition, we can take some time basically. We can probe whether there is any medications or some fluids, hypotonic fluids which cause the hyponatremia. We can address the cause. We can do some cause specific treatment. But if the acute decrease is more than 10, then it is suggested to give a single infusion of 150 ml 3% hypertonic saline over 20 minutes, and thereafter check the serum sodium after 4 hours. So the next thing, if all these three does not happen, then we can take it as chronic hyponatremia without severe or moderately severe symptoms. And the general outline for management is like we have to go for a cause specific treatment. And in only in moderate or profound hyponatremia, we have to avoid an increase in serum sodium concentration more than 10 during the first 24 hour and more than 8 during every 24 hour thereafter. And thereafter check sodium every 6 hours. And in chronic hyponatremia with expanded ECF volume, the first line management is to restrict fluid intake. But in moderate or profound hyponatremia, the next step is to increase solute intake, either with oral sodium chloride or low dose loop diuretics. And this guidelines goes against lithium or demclocycline and it recommends against Vaptans. And those patients with reduced circulating volume, here the basic step is to increase the circulating volume with 0.9% saline. So we have to manage the hemodynamic instability also. That has to be given preference over the correcting the sodium levels. So these are the guidelines which I was talking about. These are European guidelines which do not recommend the use of Vaptans in any of the cases. But in United States guidelines, it recommends the use of Vaptans as a second line drug in SIADH as well as in hypervolemic hyponatremia. And this is the danger of overly aggressive correction of hyponatremia. We know this is the brain cells which happens in the normal state, but in acute hyponatremia, when the surrounding ECF becomes hypotonic, then the brain cells swell up. But over some time, there occurs some adaptation so that the brain cells pump out some osmoles and sodium salts and then organic osmoles so that a new equilibrium is established. If on top of that, if we give a lot of hypertonic saline and we make the surrounding ECF more hypertonic, the brain cells can actually get shrunken and water will move out of the brain cells and this causes osmotic demyelination. So the speed of sodium correction is very important. Insufficient correction will lead to cerebral edema and too aggressive correction will lead to osmotic demyelination. So this requires a balance. So this is the cutoff which is told. In symptomatic acute hyponatremia, the sodium has to be raised by 4 to 6 to prevent brain herniation. But in chronic hyponatremia, the sodium has to be raised by 4 to 8 millimole per day with a lower goal of 4 to 6 if the risk of ODS is high. And the limits should not exceed those at high risk of ODS 8 millimole per liter in 24-hour period and normal risk of ODS 10 to 12 millimole per liter 24-hour and 18 millimole per liter in 48-hour period. So summing up the key points, we have to note that we have to confirm the patient truly has a hypoosmolar state by checking serum osmolality. We have to assess for serious signs or symptoms causing cerebral edema, determine the duration of development. If the duration is not known, treat it as chronic hyponatremia. Assess the patient's ECF volume status by using spot urine sodium as well as a serum uric acid level. Check the urine osmolality to see if the urine is appropriately dilute or inappropriately concentrated. Assess for the underlying causes and assess all the patient's medications and nutritional intake and look for all the drugs if the patient is taking which can potentiate ADH, for example like SSRIs. And a prompt referral to a nephrologist is needed at most of the times. Thanking you.